Welcome to Teen FND Academy's podcast, where we bring experts in FND or Functional Neurological Disorder field to bridge the gap between research and the real-world recovery. I'm Dr. Lee, and today I am super excited to join by Dr. Eva Keatley, a clinical neuropsychologist and assistant professor at Johns Hopkins Medicine, and one of the co-founders of the Johns Hopkins FND program. I know many of the followers on my channel are adults struggling with FND, and since I specialize in helping adolescents or teens with FND and their parents, I've been so waiting and very excited to bring an adult FND expert to my channel. So this is for you. Dr. Keatley has devoted her career to understanding how the brain and the body communicates, just like FND, and what happens when that communication gets disrupted. In this conversation, we dive deep into the similarities and differences between adult and pediatric FND and what truly helps patients recover, and why understanding the why behind FND is not always as important as learning how to heal and recover. So whether you're a clinician, a parent, or an adult yourself navigating your own FND journey, this episode offers practical insights, compassion, and most importantly, hope. Good seeing you, Dr. Keatley.
Good to see you too.
I am so excited to actually have you on this call and the video podcast because I have so many questions that I have been asked by adults who are struggling with FND. And my specialty is working with teens. And so there are some gaps that I may not, I have. So I was really looking forward to, and I actually met with a couple adults in my email list, and then they are so excited to hear about.
Fantastic.
Yeah,
I'm so excited to talk to you and speak with someone else who thinks and breathes FND as much as I do.
Right? Yeah. So for the audience who may not know who you are, if you could introduce yourself and kind of sort of your background.
Sure. Yeah. So I'm Dr. Eva Keatley. I'm a clinical neuropsychologist. Right now, I'm an assistant professor over at Johns Hopkins Medicine, where I am primarily clinical, working on inpatient and outpatient units. And I'm one of the co-directors and co-founders of the Johns Hopkins FND program. So really it goes back to probably my undergraduate career. I started in cognitive science with an interest in neuroscience. And during that time, I worked in some neuropsychiatric labs, learning about the consequences of different types of brain-based disorders on behavior, emotions, cognition, and got a real interest in that mind behavior connection. And then after my undergrad, I did a little bit of work in traumatic brain injury research and also trauma research. So the effects of different types of injuries and traumatic experiences and what kind of lasting problems it can lead to. And that really drove me to want to go to my graduate career in clinical psychology. So I went to the University of Windsor, specialized in neuropsychology, and spent a lot of my time in working with patients with traumatic brain injury. And in that, I spent a lot of time, or I worked a lot with patients who had concussive injuries, particularly those who had prolonged symptoms after having a concussion. And I was particularly interested in working with those patients who symptoms didn't quite match the level of injury or the type of injury that they had. And I worked with patients where their symptoms were actually getting worse and worse over time, which is not what you would expect with concussive injuries. So there was a lot of questions about why this was happening. And I continued to do research and clinical work in this domain over at University of Washington, where I did my internship, and then at Johns Hopkins, where I did my postdoc. And there I started a concussion program, which has since evolved into the Johns Hopkins FND program. So that was really my trajectory. It started out with brain injury, traumatic brain injury, concussion, and then really evolved into now specifically working with patients with FND.
Wow, that's actually really interesting because that's very similar to how I evolved into becoming where I am right now. and which was the rehab, and then this moderate to severe, TBI to concussion to, this FND field. And what is really interesting is that the most of the time when I talk to other colleagues, they sort of evolved to FND from the chronic pain field, right? As a pain psychologist. And then they see the overlap, between the pain and the FND. And then they sort of like get sucked into, the FND. Yeah. So when you're working at the Hopkins FND program, what are the typical kind of age range of the FND patients do you see?
Yeah, so it really crosses the lifespan. But I would say similar to what we see in the literature, the majority of patients are coming in around 45 to 55 years old. That's where they're starting to have some emerging symptoms and getting some diagnostic workup done. But there is quite a spread on this. I see patients who are 18 years old. I've seen patients who were in their 80s developing new functional symptoms for the first time in older age. So even though we kind of see a peak around 50, I would say it's quite variable.
Okay. I actually had a couple of individuals commented on my YouTube channel who are in their 70s and recently diagnosed with the FND. But hindsight 2020, they have been struggling with these symptoms for years, right? And with pediatric population, time to diagnosis really varies, but it's like months, if not years, right? And somebody, again, commented that it usually takes 3 to 10 years, for adult, to get diagnosis of FND. Is there any sort of like a range that you know of from the, onset of the symptom to, getting the diagnosis?
I don't know the good studies on this. I imagine it is changing so rapidly because I think there's so much increased recognition of FND over the last few years. I would say most people who participate in research studies 2 or 3 years out from their diagnosis by the time they're getting into a research study. For us in our diagnostic clinic, we're often getting patients where symptoms are relatively new. So hopefully, this is changing and patients are getting diagnosed earlier and earlier on. But certainly, I would say it's a very normal story to hear where patients are saying, they've had symptoms emerging, they've seen a handful of doctors, they're getting shuffled around from one clinic to the next and not really landing on any diagnosis for quite some time. And I'll say even within our own clinics, the wait list is sometimes 6 months, sometimes even longer to get in. So that's another serious problem is, especially in the specialty clinics for FND, it's really hard to get in. And we know that early diagnosis is so important for faster recovery. So I definitely hear what your patient is saying is that it takes a long time. It takes longer than it should be for most.
Yeah, absolutely. And this is also way too common thing, which is, sometimes painful, but because of the FND and historical stigma attached to it with conversion disorder and, hysteria even further down. What I do see, is one of the bottlenecks that I am seeing is that when a patient is given a diagnosis of FND, how that diagnosis is delivered really changes the course, of taking actions as a next step. And sort of like not so good news is that the families are confused and have difficulty understanding what FND is to begin with, let alone accepting the diagnosis. And that is sort of like sets the pattern and into the cyclical, case, of seeing 20, 30, 40 different doctors, to get the answer, right? Is that kind of similar that you see in adult population too? Okay. So that's pretty similar.
Absolutely. Absolutely. We see a lot of patients who have gone and gotten workup and the message they received was, you don't have this scary thing. You don't have this scary thing. So that's good news, but that's not actually an answer. That just leaves more questions and more uncertainty. And even when providers deliver the diagnosis of FND, it's a hard diagnosis to wrap your head around. I think even for, people who specialize in this, we spend a lot of time thinking about what does it actually mean and how do we think about it? How do we describe it? And so I'm not surprised that it takes patients and families a while to really make sense of what the diagnosis FND means. And I think providers sometimes just throw it out there and then say, look up on neurosymptoms.org or, give a website to kind of for patients to fill in on their own. And like you said, it just ends up in more appointments, more workup, more seeking more answers. And then delays and delays and delays getting involved in the right kind of treatments and getting the right.
Yeah, totally. It's the same thing, So sometimes, by the time they, families find me, I'm like a provider number 700, right? Like I've got a lot of undoing to do in terms of, right, misled information or whatever they have experienced, whether it was a medical trauma, in my channel, I call it medical gaslighting, it's all in your head, right? Or it's all psychological and it's all trauma and, or you're just making things up and all of the above. And then some, even if these individuals didn't necessarily have any known trauma, that process itself can be traumatic, right?
100%. And it just perpetuates. We know that it just perpetuates the symptoms and perpetuates the condition and makes everything worse. Just on that note, one of my big pet peeves is when providers tie it to stress. I think that's the well-intended provider, but the provider who gives an oversimplified explanation of what FND is that just doesn't resonate, right? Most people who've been diagnosed with FND have experienced stress in the past, and it did not manifest with tremors or jerking movements or seizure-like episodes or any of these symptoms. And so when a neurologist says, oh, this is all because you're stressed, that's really invalidating. And it also just doesn't make sense to individuals. So we know stress can play a role in FND. So I'm not discounting that, but I think for providers, that's an important message for them to hear too, that bringing up stress during the diagnostic explanation is usually not very helpful. And it's oversimplifying a really complex relationship.
Yeah. So I want to kind of double click on that one because I do want to definitely go into like what is FND and then how you educate, the patients with, FND diagnosis. But also I'm curious with pediatric population, like the common symptoms of FND are like, non-epileptic seizure like symptoms, and then these like motor, symptoms, whether it's the tremor, muscle twitches, weakness and gait, disturbance, things like that, or difficulty walking or balancing. And then the rest is sort of like sensory, cognitive, all of the above, right?
All of the above,
yeah. Is that pretty similar with adult population?
I think it's similar. My impression is that the biggest difference is that in adults, we might be more likely to see patients with a singular symptom or more specific symptoms, while in peds, my impression is that it tends to be a little more mixed. I'm not sure if that's actually true, but like I do see a cohort of patients where they just have hand tremors. It looks like essential tremor, it looks like a Parkinson's tremor, but it's a functional tremor. Or we'll see patients who just have knee buckling and no other symptoms. And I find with my younger patients, I'm much more likely to see more of a mixed presentation.
Interesting.
I don't know if that resonates at all with your experience. If that
100%. Yeah. With my experience, I'm the opposite. Like I rarely see a teen or a child or adolescent who have one presentation. And it can start with one presentation, right? Like the hand, tremor or like Tourette's like symptoms, right? Like vocal or motor. And then it evolves into fairly quickly now fainting, now dissociating, now disorienting, now hallucinating. And now there's a memory problem, and then now can't walk, now paralyzed. And it's just like whack-a-mole, right? Yeah. And then it just gets the mole, gets more coming out. Yeah, that is a typical thing. And then it's very inconsistent, right? Consistently inconsistent. When there is a school, like a Monday morning, all of these symptoms come up. But on weekends, when they're going to a concert, nothing happens, or Christmas, holiday and summertime, everything is gray. And then school starts, bam, kind of thing is not necessarily universal, but pretty common. thing.
Yeah. I wonder if it's a little more opaque in sometimes it's very clear that there are certain environments and certain triggers, but I will say sometimes it's really opaque. It's really hard to understand where symptoms came from, what makes them worse, what the triggers are, can become very, very vague or very difficult to decipher in adult patients. I'll say it's a mixed bag. Yeah.
And not to mention comorbidities, like when they have an FND, they also have something else, right?
Yes.
And then typically the teens that I see, again, rarely have only one FND, so to diagnosis. There's usually what I would call the alphabet soup, right? Like ADHD, OCD, anxiety, POTS, EDS, and sensory processing disorder, autism, and they're all like a mixture. And chronic pain, fibromyalgia, headaches, migraines, all of these things are kind of in a mixed bag. And I saw that a lot in the concussion clinic when they had the post-concussive, syndrome that didn't quite make sense. The constant dizziness, triple PD, stuff like that.
Right. Yeah. And I see that a little bit more in the younger folks, sort of closer to 20 years old.
Interesting.
POTS, EDS, chronic pain profile with FND. And then in my older adults, there's often questions about, is there a movement disorder? Is there Parkinson's disease? Is there a Parkinsonism going on? Is there a dementia or neurodegenerative process of some sort happening alongside, or that might have triggered the FND to develop in the first place, which makes it a little difficult because these things actually do co-occur frequently. Just like you can have epilepsy with functional seizures or epileptic seizures and functional seizures. You can have Parkinson's disease and a functional tremor or a functional gait disorder. Really complicated.
Yeah. Can be tricky for sure. Yes. Yeah. And then in my program, Teen FND Academy, and also my channel, obviously, I always like to teach and educate what FND is. And I'm really glad that you are on the same page. Like if I hear just FND is just stress, one more time, right? It's like, oh my gosh. Yeah. And the way I explain FND is it's real, diagnosis, right? People are not making things up. And then there's a different disorder, diagnosis for that, right? And then it is a brain, based, the miscommunication, network problem between the brain and the body, even though structurally the brain and the body are okay. And it is never caused by one thing. It's always, the combination of this something biological, right? Something emotional, and then something social. So that biopsychosocial kind of model is how I use to explain, just to really have this comprehensive, view of FND is never a one thing, right? It seems overwhelming, but that's the reality of the complex situation. And is it somewhat similar to how you explain FND as well to your patients with adults? And okay.
Absolutely. And I love how you just broke that down into the 3 categories. Yeah, because we can very often, not always, but very often find some sort of physiological event that happened, often in combination, like you said, with an emotional valence to it that made it particularly scary, or that a time in your life where there was a lot of anxiety or a lot of distress going on that seems to be the right conditions to have FND emerge. Yeah, agreed. And then the social context, I would say, we actually need to take a page out of pediatrics to do a better job of taking that into consideration with the adult world. But absolutely, that's a key piece as well.
Yeah. I'm glad that we're on the same page.
Yeah.
And then with the biopsychosocial, right, the way that I also explain is there's always this like a triple P, things going on, which was the predisposing factors, right? And then precipitating factors, kind of like what triggered, and then predisposing was, I would say, like what was kind of cooking in the oven, before, right, this started to happen. And then the third P is a perpetuating factor, like what is keeping the fire of FND alive. So any of this biopsychosocial triangle things can be in one of those 3, Ps, right? And so when I say, psychological, it's not just a psychiatric thing. It's more about their mindset, coping strategies or coping mechanisms, right? And their belief system and personality kind of characteristic trait of like high achieving perfectionistic who is people pleaser. And then I see a lot of them in that with FND, right? And then the social could be like family, friends, and not necessarily like their bad parenting, but like how they are responding, to the episode, and the fact that, these teens have FND, and then sometimes parents want to help, but they're not really sure what to do. So then they just revert to what they know, which is not really helpful in the FND recovery picture. So those are the things. And then like the expectations, from other people and, society and all of these other things are definitely playing a role, mostly as a perpetuating. And sometimes it could be the precipitating or predisposing. So those are the kind of like a two different triangles that always like mix, with each other, which makes it more complicated. But,
definitely. But I find that model so helpful, and really laying that out. I'll work it out with patients. We'll go through and talk about what were the risk factors that kind of might have made them vulnerable to developing FND. What were the precipitating events? If we can identify those, sometimes we can, sometimes we can't. And then those perpetuating factors are like the most important piece, because that's where all the treatment and change can happen to start decreasing, the intensity and the frequency of the symptoms.
Yeah, absolutely. Yeah. And then which kind of turns into like the treatment, or like how you help these individuals with FND recover, right? Or resolve the condition. How are you guys approaching from your perspective and in your program wise?
Yeah, so it varies a little bit from patient to patient, but within and which clinic that we're in. But within my own clinic, I do cognitive behavioral therapy informed treatments for individuals with ND across the spectrum of presentations and across 18 to older age. And it's a brief intervention. So I do about 6 to 8 sessions, really to get the ball rolling and getting some change. And the key pieces that we emphasize is psychoeducation, really understanding the condition that you have and why it manifested and what's perpetuating it, developing coping skills. And then I think a really important piece is behavioral experiments, eliciting the symptoms in session and getting some control over them in session in a graded manner. So that, regardless of what symptoms the patient's experiencing, that's kind of our plan. We try and bring them into the session, figure out what works to get them under control, and practice. And so I take a lot of patients out. Yeah, I see a lot of patients with difficulties with gait and walking. So we'll walk around the hospital, we'll walk outside, we'll get on the treadmill, just do what we can, kind of pushing the limits each time. So I borrow a lot from my rehab therapy colleagues. I'll say several of our rehab therapists over at Johns Hopkins are really excellent in working with patients with FND. And so I've learned a lot from them and how to elicit symptoms, manage them in session, and kind of get off the chair and do some movement.
Got it. I love it. Yes. And the way I teach in my, program is sort of like there's 3 steps, protocol is what, how, and why in that particular order. You need to know what FND is, and then how you get better, right? Yeah. And then there's a lot of definition around that. And then only then we talk about why this happened in the first place, instead of just sort of insisting to stay in this like burning house to figure out what caused the fire, right? Before you get out of the house and then put out the fire, right? So
totally agree. Yes.
Yeah. Because they get stuck on this, like, I need to figure out why. So then as long as I take care of the why, then I would get better. And this kind of gets into the vicious cycle of, it's got to be the trauma, like chasing after the sort of non-existing, trauma.
And I'll say that, for anyone, anyone listening, that therapists can sometimes get caught in this too, particularly if they're new to FND. They'll spend a lot of time working with patients trying to figure out that why and what happened and when can we pinpoint the triggering event. And it's really not important. It's helpful. It can be helpful to know, of course, but it's not going to, even if you can figure it out, it doesn't resolve the symptoms. So I think that's something that we as psychologists really need to do in training our colleagues about how to be helpful with patients struggling with FND.
Yes. And you brought an excellent point. This is also like the phenomena I see a lot, which is when an individual is diagnosed with FND and whoever the diagnosing diagnosing provider. Usually it's a neurologist or neurologist consultation within the ER situation or settings. And they would say, go see a CBT therapist.
Yes. Right.
And then
all the time.
any diligent, right, families will follow, okay, I'm going to find a CBT therapist on psychologytoday.com. And lo and behold, they see a, therapist with CBT experience with zero FND expertise or knowledge. Yeah. And that's what I see a lot that, well, we've been doing CBT therapy for 300 sessions and nothing is working. And been there, done that, right? So I love that you says, CBT informed, but it's not necessarily, the classic CBT as in more into this like a cognitive therapy, or let's think about how you're thinking so you can change, the thoughts and feelings. It's not that same. Oh my gosh.
Yeah. I think it's big on the behavior, less small c. I spent a lot less time worrying about cognitions and challenging cognitive thoughts.
Yeah.
But yeah. So absolutely, I agree with you. The traditional CBT can be very effective for other comorbid features or comorbid conditions, or just, promoting positive coping strategies. I think that there is some value to it, and it's probably better than nothing. But when it comes to really targeting those FND symptoms, it's not, unless somebody has some FND experience, it's less effective. Yeah.
And sometimes it can backfire, right? And it's just,
it can backfire.
Like, these teens get like really frustrated and they're like, I'm working really hard, but it's not getting better. And so they start to think, maybe it's me, like who's the problem, right? So additional sort of unnecessary dead end, plus, more of the delay in recovery.
The helplessness and hopelessness that comes along with seeing all these providers not getting better, putting in all this effort. Yeah, absolutely agree.
100%. Yes. And then some families also ask me, because they are so embedded in this conventional medical, model, where they are instructed to hyper focus on every single symptom. Like they have a clipboard, like jotting down, logging like every single symptom and episode. And they think that they have to have like 10 different providers for each and every symptom. And so that could be like the multidisciplinary, setting, and PT, OT, speech, and, dietitian, right? And then psychology, psychiatry, neurology. I mean, all of these, the thing. And then there is a definite place for that. I mean, you and I, been in that, setting, like we grew up, in that setting. I just joke, about that. Yeah. But with FND, yes, there are those cases, but with my experience, it's not necessarily needed for every single case. Would you agree with that?
Oh, yeah. Yeah, absolutely.
Yeah,
absolutely. I think that treatment plans and treatment teams really need to be individualized to the patient and, what the person's experiencing and what their priorities are. And completely agree that very often people are coming in with way more providers on their sort of roster of providers that they're going to than is really needed or necessary or helpful. And so sometimes, the first thing we do is start paring back. Okay, who's the most important people here? Who do you trust the most? Who's been most helpful? Who can we drop so that you're not spending all of your time just going to appointments and then listing off your symptoms and attending to your symptoms? Because we know that attention to symptoms and worry about symptoms and chasing down symptoms, again, just perpetuates the illness.
Absolutely. Yeah. And I call that symptom chasing behavior. And then they're like really, and then focusing on that micro, level of it. And I'm glad that you mentioned, regardless of the symptoms, here is like the bottom up, approach with behavior component and then gradual exposure, to that, episode. And then, so they're learning skills and strategies to really overcome. And I would say like start to ride the wave, without panicking,
Exactly. I love that. Exactly. Riding the wave of the symptoms, and then they start to be a little intense and a little less frequent, and you have a little more control. Yeah.
Yeah, absolutely. Yes. Yeah, this is really great. And then in terms of, I don't know if you have any like experience of, oh, these are the kind of individuals who tend to do well versus, oh yeah, these are the like, I don't know if there are any patterns as to who gets better versus not. I don't know if you had experience with that.
Yeah. I've always had my own kind of clinical theories, but I will say that a few research studies have come out looking at predictors of who tends to benefit specifically from rehabilitation therapies in adults. That kind of has turned upside down my my ideas. So I'm a little more cautious now in terms of making predictions of who I think will benefit and get better. Because historically, there's been this idea that patients who have really severe chronic pain, chronic fatigue, tend to not benefit from rehabilitation therapies as much, or cognitive behavioral therapies, because the pain and fatigue gets in the way of really engaging. But that's actually not kind of fleshing out in the intervention research that we're seeing. So that has been a very recent and interesting finding. And in fact, the thing that seems to be floating to the top as a really strong predictor of what can predict a good outcome post-intervention is someone's perception of their control over symptoms. So how much personal control, how much self-efficacy do they feel they have in their symptoms, which, is a little bit of, you can imagine people have more control, might have fewer symptoms. There's a little bit of a tautological reasoning here, but I do think there's something there about control of symptoms, feeling like you have some sense of agency over what's going on, being a really key ingredient to benefiting from treatment, and should also be a key ingredient target for treatment interventions. Because I think that is a really important. Yeah. I don't know if that resonates with kind of what you've seen and what you practice.
100%. Yeah. In fact, yeah. And this is coming from the chronic pain kind of treatment, world. But, in the beginning of the program, I say you have to have these two ingredients if you want to get better from FND. And one is a sense of control, the empowerment, right? Especially from teens. And because they're already coming in with this like experience of, well, there's nothing that I can do, because when an episode happens, it's going to take over, my body, and I don't really know what to say, what to do. And so it's that belief that you can actually take, control back, of your brain and body. Right. And then the second part is the self-awareness. And it's not so much of like, I can feel, the warning sign of episode coming, but it's everything else. For example, it could be a trigger for a symptom, but to me, more about, this is kind of getting into the why, phase of it, but like, are they actually able to experience what they're experiencing internally and articulate what they're experiencing, regardless of that, in the name of communication with themselves and others? And this kind of ties into the kind of characteristics of teens that I am working with, which are this high achieving, perfectionistic, who is very much people pleaser. And so they are, I don't know what else to say, self-sacrificing or self-sabotaging, right? And I'm not saying that's the reason why they have FND, but that is one key element of sort of becoming FND free when they are able to express and communicate their internal experience and then their own needs. And so I kind of talk about, I don't know what else to say. This is emotional constipation, right? Something happens. And if they're either not being honest themselves or matching, others' needs, before them, then it just like starts to accumulate, and then it's just like constipated. So part of the thing is a cleanse, right? And so those are the two kind of key elements. I'll give you a heads up. These are the absolute two ingredients that's not negotiable that you're going to be building, throughout. And those are the ones that would really thrive beyond FND and versus not.
Yeah. It's interesting because there's a kind of a debate, I would say, in the adult world about how much time to spend on that emotional awareness and expression piece. in FND that I don't think we really have an answer to. And it probably depends so much on the individual. But I agree. I mean, I see patients who have difficulty recognizing their emotions and expressing it, or we often refer to it as alexithymia. Can be a little more difficult to kind of get in there and understand what's going on and find some treatment targets. So yeah, I absolutely agree. That's often a red flag early on if I find myself having a hard time getting that internal experience, or getting the individual to explain to me their internal experience, because they're struggling to understand it.
Right?
Yeah.
Yeah. And then in terms of the actual work, I agree with you that I am heavily on ground, a lot of nervous system regulation strategies. And so the goal is not to avoid or prevent an episode from happening, but really starting with how to respond, to an episode, regardless of the symptom or what kind of episode it is, with calm, sort of like a manner. And again, like a rite of wave. And then over time, the fear response is the main target that we're going to tackle. So then if you don't have the fear or concern or frustration around the episode or thinking about having an episode, then the episode itself becomes less significant over time. And so then they can kind of start getting back to, their life while they're working on that nervous system regulation. And then eventually along the way, the sort of like symptom really doesn't really need to be there, right? Yes. As opposed to the only way to measure the progress and success is the elimination of symptom. Then it goes back to, right, the symptom chasing behavior, and it's all or nothing, right? It's like, yeah, I'm better, but I still have an episode, then it's like, that means I'm not better, right? So it's a little bit nuanced thing, but do you see that sort of like making a difference?
Yeah. Well, and I think your point about, not just the point is not necessarily just to eliminate the symptom. You've got to have a more like holistic approach, because so many times patients will come in and say, with tremors or movements, but that's not the thing that's the most disabling, right? It's like all the other things that are going on as well, the fatigue, the pain, the intermittent episodes. And so getting rid of the hand tremor, for example, doesn't actually change the quality of life. And I think as academics historically in the research, that's been one of the limitations, is that it's been really focused on getting rid of symptoms and kind of missing the bigger picture of functioning. And so I know, stakeholders, different individuals with FND have been saying to academics for a long time, like, you can't just focus on that one symptom. That's not the only thing that matters. It's that plus everything else that we experience that's having a big impact. And so going back, I think exactly as you're saying, if you have confidence in your ability to manage symptoms when they emerge, or manage whether it's distress or physiological symptoms, and you feel like you've got a good handle on how to support yourself and help yourself and remain functional during those moments, that's what really leads to the better outcome, more so than just getting rid of symptoms.
Yeah. Absolutely. Yes. I'm 100% with you on that one.
I know. It's so nice. Yeah. I think we're thinking so similarly. It's great.
Yes. So part of the definition of recovery is one of the first things that we do in the program. Nice. And by setting a goal, right? But the goal is usually they come in with what they don't want to have anymore. So the goal is, I don't want to have FND anymore, or I want to get rid of it. And so then that is usually where we start. Well, instead of thinking about what you don't want, let's start thinking about what you want, like when you're done, with FND, or when FND is no longer an issue or the centerpiece, at your table, right? And so this is where I start to teach, what you really want to focus on is the quality of life. So then functioning, right? Daily functioning, and also learning the skills and strategies to master this resilience. Yeah. And so they can come back from anything and everything beyond FND. And these teens are actually learning these skills and strategies to be truly resilient. So I hear from some families who either finished my treatment in my private practice or the program, and they write to me like months and years later saying that, oh my gosh, my daughter is now in college and doing great, like any struggles and obstacles in their life, it's just, they're like approaching, with confidence. And so it doesn't have to be just applied to the FND of what they're learning, right? So that is where the mindset really shifts. So it's not just about the elimination of symptoms, because otherwise they're just looking, when is it going to be over, right? Yeah. And that's not really helpful to focus.
No. Yeah. No, I agree completely.
The Family Guy shares a handful of practical strategies to help you get out of this survival mode. And it shows why our structured approach gets such a strong result. Grab it from the description below. It is free.
So then the goal setting for you and in your program is also kind of focusing on the quality of life and functioning. And those are the things. Okay.
One of my favorite questions to ask that I ask every time I meet someone new is, if I could take a magic wand and sweep your symptoms away, what would you be doing differently starting tomorrow? What would you, what would your morning look like? What would you do with your day? And how someone responds to that question is really, really telling, because I'll have people tell me, oh, I've got, all of these things that I've really put on hold that I really want to get back to school. I want to go out with my spouse. I want to get back to, take my car and go for a ride. So that helps me really identify some really specific functional goals. I also sometimes get the answer of, I don't know what I would do, right? I have no idea, because they've been so embedded in sickness for so long that it's become all-consuming, dictating sort of day-to-day routines. And that's really telling too, because if you don't have things that you're working towards and you don't know what you value and what's important to you outside of sickness, outside of an illness, then it's really hard to find a direction and the motivation to emerge out of that illness. And so that tells me we need to spend a little bit of time doing that exploratory values work, because that's critical, like you said, to understand where we're going and how we know we've been successful, because just getting rid of symptoms doesn't do it.
Yeah. I 100%, agree with that. And then this kind of ties into what we were talking about earlier of this, like over time, this becomes their identity. And that's closely tied to the learned helplessness, right? So like, been there, done that, there's nothing I can do, therefore I have to live like this, forever. Disabled, right. Whatever that is. And I don't think that's a bad thing. Some people are okay, with that, right? So it's more about the choice in what they value. Yeah. You have to, and timing is everything too. I think, sometimes, something it has to be the right time to engage in treatment, and sometimes it's just not the right time. And that's okay too. I've definitely had worked with people who probably needed to go through some additional work or try some other things before they started with FND related treatment, because they just really weren't ready to, like you said, kind of take on all of the work that it requires. You really have to make the choice to get better and the choice to engage fully in a new mindset, a new way of responding to things. And that's not always easy to do. Absolutely. Yeah. This is really helpful. And I am so glad that there are a lot more similarity between pediatric and adult.
I think so.
Like that, right?
Yeah, I think so.
Yeah, because I saw in the literature that, the occurrence of the childhood trauma is higher with adult FND and then with pediatric. And it's not like that overnight, there's going to be more trauma, added to the adult population. But a recent study actually said that, with the pediatric FND, the trauma with big T or something substantial is actually less than half of the, case. So it's not just, oh, it's gotta be the trauma, that insisting, oversimplifying, thing.
Yeah.
Just like, this is stress, kind of thing. So
that's interesting. That's interesting that it's higher in the adult. Well, I'm not surprised, just because I think it's with a few pediatric cases I've seen, that really wasn't part of the history. I do see it a lot in adults, but I see it a lot in adults across conditions, right? Like the base rates of trauma and in chronic illness in general, or in is actually quite high in neurological populations outside of FND is actually quite high. It is higher certainly in FND, but
yeah,
I think very often I'll see it in individuals, and I ask about the trauma history, but it's really not a big part of why they developed FND 50 years later. And I try not to retroactively draw conclusions that we really can't substantiate and aren't necessarily helpful either. Sorry, I'm getting hacked.
Right. That's okay. Love it. Yes. And yeah, this is amazing. This is really helpful. And I always like to leave some sort of like either small or a nugget of practical things that individuals struggling with FND or people around them, can do, whether it's a mindset shift, or something that they can, do today, right? Relatively easy toward recovery, whatever that means for them. Do you have any recommendation or anything that you can think of that might be helpful? I know there's
although it's not, I don't know if it's a simple things, but I've got a couple of foundations that I talk about with every patient that maybe I can offer here as a thought. I think the first thing that I always check in with everybody is about making sure that basic needs are being met in terms of general health and wellness. And what I mean by this is really the 5 pillars that we talk about in brain health, which is getting adequate sleep, getting adequate nutrition, hydration, social connection, activity, and then reducing toxic chemicals. And when working with patients who have FND, we'll go through some of these and find that really their basic needs aren't being met because they're not sleeping at all, or they're drinking alcohol heavily, for example. And I think when those basic needs aren't being met, it's really, really hard to get better with FND. And it's not to say that those, improving your sleep is going to improve your FND symptoms necessarily, but I don't think you can get better if those foundations aren't strong, or it's really, really going to be an uphill battle if you're trying to treat your FND symptoms and your gas tank is empty and you're struggling to get through the day anyways because you're not sleeping enough. So that's kind of the first thing that I would recommend everyone just check in with yourselves about whether your basic needs are getting met with these things. And if not, make sure to address them. And then the second thing would be, to our earlier discussions, to gain some control, some efficacy, self-efficacy in managing your symptoms, is figure out your FND response plan, or what I call the response plan, which is 3 to 5 strategies that can help you in the moment, before, during, or immediately after a flare of symptoms or worsening symptoms. So this can be a breathing technique if you need to calm or regulate your nervous system. It can be a grounding strategy like 5, 4, 3, 2, 1. It can also be a coping statement. It really has to be individualized, but something you can carry around with you and help you get some control in those moments when your FND is really flaring up. So those are kind of, I think, ingredients that are important for anybody, no matter what you're showing up with or where you are in your recovery from FND. And then the final piece would be making sure you're directing your social support, talking to your loved ones, your friends, your family, other people around you about what do you need from them, particularly when your symptoms flare up. Are they taking charge in those moments, or are you remaining the captain of your ship and kind of letting them know what you need? Because I think it's very easy in those moments where you're feeling very vulnerable and helpless to kind of give up control. And well-meaning caregivers will step in and take over. But I think a big part of that recovery journey is making sure that you're in the driver's seat, you're the captain of your ship, and you're telling people what you need from them in those moments.
Absolutely. Yeah. And it ties back to that sense of control and, that the efficacy part. Yeah, that totally makes sense. And it's pretty identical to what I teach in terms of let's get that foundation, going. And I use this analogy of I think of an FND as a tree, and then each and every symptom is like a branch, right? So if you're just focusing on just branch, oh my God, I need to duct tape this one branch over here, and I got to do this special treatment, for this branch, then you're kind of losing the whole picture if the tree is not doing well, right? And so, let's focus on that, growing a stronger root, soil is, good, and then there's water, right? And then the sun. So that is the, general health, and also who is in charge, right? And then what is the caregivers and parents and other people's role? They're not to climb up the, tree and then start, taking over, right?
Yes,
so,
exactly.
So that's kind of like that.
Exactly.
Yeah. Yeah. It's really aligning, with this generally this rehab, model, right? Yeah, absolutely. That totally makes sense.
we see, that's the thing, is that I really want patients, clients, people with FND to hear and to understand that FND is a diagnosis of hope. You absolutely can get better. It is manageable. Symptoms get better. Symptoms, you can get some control over your symptoms. You can get back to doing the things that are meaningful. It really is a diagnosis of hope. And I think that there is a myth that you have to kind of live with these symptoms forever, that they'll continue to wear on you for the rest of your life. But I really believe that with the right treatment, the right providers, the right care team, patients end up stronger, more resilient at the end of their journey, just like you were saying, because they've developed so much strength and confidence at managing struggles when they come up.
Yeah, absolutely. Yeah, this is really, really helpful. And a lot of adults with FND have been sort of left, alone, in this, right? Just floating around. And, the lack of provider, right? Lack of specialists, access to care, all of these things are real. And that doesn't necessarily mean they can take a one step, towards recovery. And I really hope that this conversation gives, the hope, right? To those individuals struggling with FND. They don't have to live like that forever. So
yeah. I agree. Yeah.
Amazing.
Absolutely.
So if anyone wants to come see you, and I know there's a huge wait list and stuff like that, how does it go usually? Is there a referral process, or can they just call you guys and make an appointment?
Yeah. So at Johns Hopkins, we have something called the Johns Hopkins FND program, and it was founded by myself, Dr. Ali Buchholz, and who's another neuropsychologist, and Dr. Jason Chua, who's a movement disorder neurologist. And we have multiple different branches of care depending on patients' needs within that program. So we do have a website. That's probably the best place to get the most comprehensive, up-to-date picture of what the different branches of those programs are. But essentially, if you've been diagnosed with FND, you can call and make an appointment. And they, depending on a number of factors, the schedulers might ask for a referral from physicians. But I see patients for FND, often in consultation. Sometimes I see patients for ongoing treatment. So I have a clinic with fellows who also see patients. And we also do diagnosis for especially with patients where there's a lot of comorbidities and can be difficult to disentangle from Parkinson's or other types of movement disorders. Mm-hmm. We also have an EMU where patients get diagnosed with functional seizures, because that's the gold standard is video EEG for functional seizures. And my colleague, Dr. Buchholz, is really excellent in working on the inpatient unit and on the outpatient unit, providing some education and coming up with treatment plans for that presentation. Yeah.
Great. Yeah. I'll make sure to drop a link in the description for your website. And so they can find how to get the help. And so they don't have to be, helpless forever. So this is really great, helpful. Thank you so much.
Absolutely. Thank you so much for having me. I think what you're doing is so incredible. The number of people that you're able to help and sort of, increase access to care is so highly needed. We need similar things in the adult world. I think there's more stuff coming out soon, but it's been just lacking for so long. And it's just unrealistic to expect that patients are going to have access to specialty clinics everywhere. The condition, FND is so common and is so prevalent that we need more access to care. We need more providers getting interested and educated about how to help patients with FND so that there's not so much of a bottleneck to get access.
For sure. Yes. And this is the first step, right, of having the awareness and then really knowing what FND really is and is not, right? So thank you so much again for coming on, and I will talk to you soon.
Great. Thanks, Dr. Lee.
Thank you. Thank you.
Wow. A huge thank you to Dr. Keatley for sharing her expertise and her wisdom with us today. It was so delightful to have you. And I hope this conversation reminds you that FND is a diagnosis of hope, that recovery is possible, that progress happens one step at a time, and that understanding your body is one of the most powerful tools in recovery. If you'd like to learn more about the Johns Hopkins FND program, I have linked their website below here so you can explore resources if you're in that area and get connected with care. If you want to see how my full program of Teen FND Academy works and how it's helping families resolve FND for real, then watch the video linked in the description box below. And as always, if you or your teen are navigating FND, remember that you're not alone. You really are not. Here at Teen FND Academy, I am literally committed to helping you move forward from fear to confidence and from surviving to thriving. Thank you so much for watching this video, and until next time, keep taking those small steps towards recovery. Bye for now.